Our next lecturer is going to be Dr. Deborah Taylor. Her talk is entitled Myth Busting, Human Milk Feeding Today. Dr. Taylor got her doctorate in medicine from the University of South Florida College of Medicine. She then completed her residency in OBGYN at the Medical College of Georgia. She is currently at Wellstar Kennestone Regional Medical Center, where she serves many roles. She's the clinic director of GME. She is also one of the core faculty members, and she's the director of the OBGYN electronic health records for GME. Her current research includes resident education to address implicit bias and racism, as well as how to standardize ultrasound learning in a community residency program. Dr. Taylor has earned several teaching awards, both from faculty when she was a resident, as well as from medical students. Please welcome Dr. Taylor.
I don't always get to feel tall. This is great. Dongle's not on. That piece is in here. I don't know if it came. I don't know. Technology is always my friend, or not. Good morning. Thank you so much for the invitation to speak today. This morning, it's easy for me to say I have no financial disclosures, although obviously anybody is welcome to pay me for this. The biggest disclosure I have today is you can hear my children were very generous with their cold virus, so we're going to hope that I make it through this without killing your eardrums with coughing. Our objectives today are pretty standard. We are going to spend just a little bit of time talking about the changing terminology in not only our healthcare system, but particularly as it applies to lactation. We are going to talk about ways to look for opportunities to standardize your evaluation of your patient when they come to you and say, thank you, that they are really committed to this breastfeeding journey. My favorite part is we're going to use our inner nerds to apply scientific principles to the myths that we hear from our patients every day in our office. And then lastly, I hope to give you guys a couple of resources, some that you may be already aware of and some that you may not, so that when you walk out of here totally psyched to have these breastfeeding conversations with your patients, you have a good idea of where to look for help when you need it. So, when I finished residency 15 years ago, I had never had a conversation with a patient about a pronoun. And it's just part of my everyday. Hey, I'm Dr. Taylor. I'm she, her. What would you like me to call you? And I'll confess that I don't always understand where this comes from because it's not a part of my personal experience. But we know that all of our patients who deliver with us do not necessarily identify as female. We know that there are trans men who carry pregnancies and provide milk for pregnancies. And in this DEI world that we live in, to be inclusive, we really need to make the effort to change some of the terminology that we use on a daily basis. So I'm going to do my best. We also have talked for a long time about the difference between exclusive breastfeeding and formula feeding. And there's this new place or new opportunity where we can talk about inclusive breastfeeding, right? For those moms who worry that they don't make enough breast milk, they can supplement and still continue to provide their milk. It doesn't have to be an either or. We can talk about milk expression and pumping. We can talk about exclusively pumping, which I didn't even know was a thing until recently. And then this idea of triple feeds. A triple feed, for those of you that may not have heard this term, is when you nurse the baby, pump, and then give the baby back the pumped milk. It is exhausting, in case you're curious. ACOG has made it clear that they want obstetricians to take an active role in supporting human milk feeding. And it's not just ACOG. It's the CDC, it's the WHO, it's the AFP, it's the AAP. Anyone who cares for these patients has a statement that says human milk feeding is important, and you, as the doctor, have the opportunity to support this. There was a committee opinion that came out in 2018 that talks about optimizing the role of supporting breastfeeding in your practice. And it's a great read if you guys haven't read it recently. It's also very telling to me that one of the past presidents of the AAP in 2018 as well made the statement that breastfeeding isn't just important, it is an integral decision in the health of an infant. So, let's go. I'm not sure how many of you remember this show. It ran for a really long time, from 2003 to 2016. And when I talk about my inner nerd, let me just tell you, these guys are my idols, right? They would take a myth, they would set it up. They did the Titanic one, the lady that survived on the door, and set it up to see if that was true or not true. And their principles were to take this myth and then use science to say yes or busted. I promise not to twirl my mustache too much, but I feel like I do this a lot in my practice when I talk to people about human milk feeding. So let's meet Sarah. Sarah is a 25-year-old G2P1. She's coming into your office for her confirmation of pregnancy visit. And you have an opportunity, right? Because you're going to talk to her about it. And ACOG says, use this opportunity to elicit what they know. So Sarah, what do you know about breastfeeding, right? Give them the opportunity to show you their level of education about this issue, their level of interest, and of course, what their mama told them about it, right? So Sarah says to you, you know, Doc, I've heard that breastfeeding is good, and I'm a little worried about the formula shortage, but, you know, fed is best. Okay, myth number one, right? There is this whole foundation that was set up by a physician and a registered nurse. The physician had a very unfortunate negative experience with exclusive breastfeeding, and she felt called to make this mission to ensure that no baby is ever malnourished. And we can all get behind that, right? 100%, no baby should starve. But the slant of this foundation is very, very biased, and so I would be careful when you have your patients say this, that you recognize where this information is coming from and that you have a good way to kind of talk through it. Because the fact of the matter is, this isn't even a hard myth to bust, right? There is no doubt that the components of breast milk are more better than the components of formula in a number of ways. The one that we talk about often is the immune support that you get for these babies in the very early months of their lives, right? We know that the antibodies that the baby gets from mom will decrease the active infections that they're exposed to. And it's not just early in life that this breast milk, this human milk, has the opportunity to make a big difference. When you look at the data for risk reduction and you plug in 6 months of exclusive breastfeeding, there are lifelong improvements for that infant. Not only do you decrease your risk of sudden infant death syndrome, but you can reduce your risk of ADHD. Cool, right? You can decrease your risk of obesity, atopic dermatitis. The risk for the baby for their lifetime changes dramatically. And our babies that are at the most risk have the biggest benefits. Breast milk has a protein in it that is tailored to these tiny humans that live in our NICUs. We know that breast milk can drastically reduce the risk of prematurity retinopathy. It reduces the risk of neck by 77%. All comer infections, it reduces by 50%. And if anyone's had a NICU baby, you know you're worried about them going back to the hospital. And breast milk reduces the risk of readmission. And we are so lucky in our state to start to have the opportunity for many of our hospitals to have access to donor milk. So do you know if your hospital has a donor milk program? Do you know what the criteria are? This is a great place to start when you're looking for resources. It's not just the infant, it's also the parent that has amazing benefits from breastfeeding, right? We've talked a lot about the reduction in breast cancer risk. Okay, cool, I knew that. And we talk about the reduction in metabolic syndrome, right? And all of us a little worried about metabolic syndrome, so that's good. What I didn't realize, and this seems so timely, in the setting of Georgia being 50th in our maternal mortality, and hearing again yesterday that cardiovascular disease is one of the main killers, breastfeeding for 6 months reduces the risk of stroke in the parent by a quarter. And in Black women, those women who are disproportionately affected, who we know are more affected by their maternity and mortality, you can decrease their stroke risk in their lifetime by almost 50%. So when Sarah says to you, fed is best, that's a hard stop. Let me tell you about it. Let me tell you about the benefits. So then, you go about your way, your busy way, seeing many patients, and you don't see Sarah again until she comes in for her ultrasound, right? We're about the halfway point. And you say, Sarah, how are you? And they say, Doc, I'm so excited. I thought about what you said, and I am going to breastfeed, and I'm committed. I just wish that there was some way that I could predict whether or not I was going to be successful, or like I could prepare to breastfeed. But I know there's not any way to do that. Okay, well, remember that ACOG committee opinion? What does success look like for you? For some families, successful breastfeeding means that there is no formula at any point, not even drops, right? And for some families, I'd really like to be able to give the baby some of my milk. But if we use but my plan is also to use formula. I have to go back to work at 6 weeks, so I'm going to direct breastfeed for that 6 weeks, and then when I go back to work, I don't want to bother with pumping, so that's what I'm going to do, right? We have to be careful that we couch our encouragement in terms of the success that they want, right? Because if I am like, you have to breastfeed for 6 months, this baby can't have anything else, and this lady's thinking, this doctor has no understanding of what my life is like. I've got 2 kids at home. I work full time. I'm an OBGyn, right? I can't do that. You have to be mindful of what success looks like for that patient. And then, we go back to medical school. Everything starts with a good history. I am happy to talk to you about your ways that you can be successful, or look for pitfalls that might get in your way to be successful. Let's talk about any metabolic disorders you have, PCOS, thyroid problems. Let's talk about any surgeries you might have had, a breast reduction or a breast augmentation. Let's look at what your family history is like. Your mom nursed 6 kids. Your sister couldn't nurse at all. Let's look at what your history is and see if we can find places where we can intervene or help. And then let's do an exam, right? The easy part is the surgeries. Scars, no scars, cool. But you also have to think about looking for undiagnosed goiters, or looking for something called insufficient glandular tissue or tubular breasts, right? These are patients who, in the course of their pregnancy, don't really develop any changes in their breasts. And these are patients that you may want to start to talk about, hey, you may not be able to exclusively breastfeed, right? but you may be able to give some milk to the baby, and let's get you hooked up with a lactation consultant, and let's talk about what that looks like, and let's make sure we can optimize your human milk expression. You can recognize inverted nipples. Now, this used to be a really big deal, and there used to be things that we encourage people to do before the baby was born to try and evert those nipples. And really, we know that this is a latching issue sometimes, and it's really not addressed in most hospitals until the postpartum. But this is a patient that you're going to want to say, hey, I'm so excited because we have a lactation consultant in our hospital that will see you the day the baby's born that can help you work on how to evert these nipples to make sure that you have a good latch, to make sure that your human milk expression is great from the beginning. And then preparing, right? All of us sitting in this room are always looking for ways that we can get one step ahead on the next certification that we have to do. I was saying at dinner last night that I really think that one of the silver linings of COVID is the plethora of online resources, telehealth opportunities with lactation consultants if you don't have them in your community or in your hospital, breastfeeding classes. In my hospital, we have a very robust lactation services, and I'm grateful for it. When COVID hit, they pivoted from their in-person classes and their in-person support groups to online, right? I'm still not a fan of video conferencing, but the fact that I have a patient who doesn't have to worry about her access or that her work hours don't line up with the group at the hospital, who now has access to all of these great online references, is amazing. And I hope that even as we come back to in-person, that we never lose that option of doing things online. When we talk about suppress, we also want to make sure that the patient knows about antenatal colostrum expression, right? Stanford has an amazing video on hand expression, and there is those patients who maybe have PCOS or pre-existing diabetes or some kind of thyroid problem. You can actually teach them how to hand express colostrum and then collect it so that when they get to the hospital, if there's a delay in the milk coming in, instead of needing to supplement with formula, you have this antenatal colostrum that you've kept that you can bring with you to the hospital, that you can ensure the baby can transition well. In a pregnancy without difficulties, the recommendation is usually that you start antenatal colostrum expressing no sooner than 36 weeks. And then you can always tell Sarah, don't forget to buy all the things, right? Because breastfeeding these days comes with all the things, and we're going to get a little more into this with the resources. So Sarah is pumped, right? She and her family have made this decision. They get to labor and delivery. Everything is great until it's not. One of the things that we have to keep in mind is that the things that happen on labor and delivery, right, a prolonged induction, if we're following the Arrive trial guidelines, or an unexpected C-section, or a baby that goes to the NICU that we hadn't planned on going to the NICU, and so you have separation of the dyad, right? We need to be mindful of those things that get in the way for early latching and early skin to skin so that we can be proactive in advocating for our patients regardless of what the complications are. So then we get back to the myth busting, right? I feel like every time I see someone who's nursing postpartum day 1, I'm not making enough milk. I'm worried the baby's not going to get enough milk. And this is one of my favorite graphics. It's okay, right? The baby's stomach is this big, and what you're making is enough. And what you make increases as the baby's stomach gets better. And if the baby's not losing weight and the baby's wetting the diaper, we are doing fine. You are doing fine. This is what it's going to look like. Be proactive in educating them so they don't have to worry about not having enough milk. A lot of us are making contraceptive decisions in the hospital. You know, at Wellstar, our patient population is probably, our obstetric population is probably 50% Medicaid for OB, some uninsured. And so a lot of times we are looking to make sure that our patients have good decisions and good plans for their pregnancy intervals, for spacing, in our population that often has access to care barriers. And so we often are talking about contraception on postpartum day 1 or postpartum day 2. In our hospital, we do post-placental LARCs, both IUDs and Nexplanon. And so you want to make sure that the choices that you're making with contraception are in line with the patient's goals for success, and their history. If Sarah tells you that with her first baby, she never felt like she made enough milk, then you maybe don't want to pick any kind of hormones for her, because even though the data says that postpartum day 2 Nexplanon doesn't impact your breast milk supply, we all know that patient that it did. So if her goal is this, make the choices, have the conversation that you can support the family in their goals. This is a really neat app. One of the things about working with residents is I get to stay cool. They've always got some kind of app on their phone that helps them do this or helps them do that. And this is a really neat one. This is an app put out by the CDC, and it goes through the medical eligibility criteria for contraception. And so you can, on your phone, pull up the condition that you are worried about. You can pull up the contraceptive method you're thinking about. You can say, okay, breastfeeding is the concern that I have. And it'll tell you level 1, level 2, level 3, level 4. It'll tell you how you can make choices that support your patient. And it's great, and it's free. I like free. And then, Sarah goes home from the hospital early because we're short-staffed. And she has a beautiful rainbows and unicorns breastfeeding journey that we all think is amazing and natural, right? Because human milk feeding is natural. Except it's not always. There was a great article that came out in June of this year in the Green Journal, and it talks about the changing terminology, and it talks about all of the different technologies that we have available to ourselves and our patients that can help them get that expressed milk and have it for their infant. If you guys haven't read this, and obviously CME is always a good thing, I highly recommend it. It's a must read. One of the things that changed is pumps. I'm sure that breast pumps were around when I had my older son 3 decades ago. I don't remember that. When the Affordable Care Act passed, insurances were obligated to cover breast pumps, and we started talking about it a lot more. There have been some changes in the way that the law is interpreted, and now there are limitations on pumps. Some of our Medicaid providers, for instance, will only provide 1 pump every 2 years or every 3 years, so you can't necessarily get one for each baby. The schematic is kind of the basics of what a pump looks like. There's some kind of device that attaches to the breast. There's some kind of way that they interface, and then there's some kind of a mechanical pump that helps express the milk. On the top left corner is something called LVs. Anybody know what these are? So these are almost cool enough to have another baby, almost. The green part attaches to the breast, and these sit inside your bra. So Christy Teigen has LVs, and they're wireless, chargeable, rechargeable. The bottom part that's clear is the place where the milk is, and you literally put them in your bra and go about your business. And it's only one of the wearable options that they are. When I had my last babies, I used something called a Free Me pump, which is 8 ounces, and it's about that big, and it clips nicely on your scrubs, and it has cups that can go with you. And my residents will tell you, I pumped in the OR, I pumped at didactics, I pumped on rounds, I pumped in the clinic. And it wasn't quiet, but it wasn't loud, right? So it's okay. And you should see the husbands make faces when they ask, what's that noise? And you tell them. That bottom pump is kind of the Cadillac. This is a Symphony by Medela. This is the pump that you'll see in a lot of NICUs. It's the one we have in our NICU. One of the ways that our hospital has chosen to support our NICU families is for as long as your baby is in the NICU, you can rent for free one of these hospital-grade pumps, because we know that in that preemie population, the breast milk is so important that our hospital has invested this. And it'll get the job done. Once you express the milk, then you also have to have ways to store it, and this is another place that things have really changed. In the center is plastic bags. These have been around for as long as people have been storing milk. In the exclusive pumping community, there are all of these ways to maximize your storage. This is called a brick, and you want to get them as flat as possible. You do this by putting them on a cookie sheet in the freezer so that they freeze flat, and then you can stack them. So you can maximize the storage that you have for this breast milk. On the left is the Kind system. This was really fancy. It's an all-in-one deal. You pump straight into the bags get stored, and then there's a bottle attachment, so you don't have to take the milk from the LV and put it into the bag, and then take it from the bag and put it into the bottle. And a lot of the moms that I know who are physicians really like the simplicity of this system. And then for those of you that have hippie tendencies like me, you can even use mason jars. There's a whole system to use glass mason jars where you can put the milk into it, freeze it, heat it back up. You even can buy a bottle attachment that goes on it to minimize the loss. And it is really cool things that we've managed to do for this storage system. So remember that technologies part? That's all pretty straightforward, but there are some parents who are not able to express enough milk. Sometimes this may be a patient who has had a baby through surrogacy, who's tried to induce lactation through one of the mechanisms. Sometimes this may be a same-sex couple where one has carried the baby and the other is wanting to nurse also. This is called an SNS, a supplemental nursing system, and the picture that you have up is from Medela. So, yeah, I'm not that fancy. So there is a receptacle for the breast milk that hangs around your neck, and then there's tubes that you can see in the picture. The tube runs from the receptacle to the breast and is attached to the nipple, so the baby can latch onto the breast and stimulate the breast, which we know induces the production of more milk. And if you're worried about supply, because you have that IGT or whatever problem that you're concerned about, you get to have that bond of direct nursing and not be worried about the amount that the baby's getting. In the physician moms that I talk to, one of the things that they say that they don't like about direct breastfeeding is that they can't tell how much the baby's getting, right? I'm not saying we're detail-oriented or anything as physicians, but if you're worried, then you can keep track of the volume through this SNS system, right? And then the other pictures are just myriad things that have come to market to help. You can do spoon feeding if you're trying to avoid an artificial nipple. You can do syringe feeding. In our institution, we have all of those things available, but you have to ask for them, right? So let's say that you have a baby that does have a 10% loss that PEDS is worried about, and mom's milk hasn't come in, and you missed the opportunity for antenatal colostrum. And so you're going to give the baby formula because we don't want a malnourished baby, rather than introduce the bottle, right? We've all seen them on L&D, on postpartum. You can ask for one of these other options. And if they don't have it, you can do it yourself. You can spoon feed a baby the formula so that there's not any kind of confusion, so you can avoid that concern that you might have. And then you got to have the stuff, right? Did I say there's stuff? These are specially manufactured pillows who are only to support the baby when you're breastfeeding. right? And, I don't know how anybody ever did it without these pillows, because clearly you need to buy them. You should coordinate it with your nursery. Don't worry, that's available. And they run, depending on how fancy you want to be, these are base models, right? On the left is a boppy, on the right is My Breast Friend. The boppy runs about $50. The My Breast Friend runs similar to that, somewhere in the $50 to $60 range. If you have multiples, they make special boppies and My Best Friends for twins, so that if you're trying to direct breastfeed, we call that tandem feeding, you can support both babies. But the fact of the matter is that plenty of parents provided human milk for their babies for years and years and years without these fancy pillows. So if you have a patient who doesn't have all the things for whatever reason, that's okay too. It really is just about positioning and finding a good latch position that works. All right. So Sarah is doing great. She goes home. She's doing great. And then the phone calls come, right? Because this happens. People go home. They worry. They have their mama or their auntie or their boyfriend's mother's cousin's friend, my personal favorite, who starts telling them things, right? And they worry. So you get this phone call, and it's the same one, right? I'm worried I'm not making enough milk. This, the caption in the top right is a little bit hard to read. It says, weight gain and nappies. These are the only things that tell us about milk supply, right? If the baby is gaining weight appropriately, and if the baby is wetting diapers, the baby is getting enough milk. Period, the end. People are like, well, my baby wants to nurse every 2 hours. Yeah, unfortunately, that's normal. Sorry. Well, my baby doesn't sleep through the night. Okay, A, your baby's 6 weeks old. That's okay. B, some babies don't sleep through the night for a very long time. So when you have patients that are worried, you're not going to be able to say, the baby's growing and the baby's making wet diapers, you're going to be fine. Okay, sometimes you can, but not always. So you want to talk about frequency, right? Boobs are amazing things. They work off of supply and demand. The more you ask, the more you get. So if you have a patient that's worried, you tell her, okay, make sure you're putting the baby to breast, right? The best thing that you can do to increase your supply is to ask more. Frequency, 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 frequency. In the exclusive pumping community, there's a lot of talk about this thing called a power pump, which is a 20-minute pump with a 10-minute rest, another 10-minute pump, a 10-minute rest, and another 10 minutes, right? So that's an hour of your life that you're dedicating to this. And the idea is that even if you don't get expressed milk with this pump session, that you're setting yourself up to have more later. So power pump away. And then in the middle, this is called a haka. This was a new thing for me. This is a passive milk collection device, right? So a lot of times when patients nurse one baby, they'll have the baby on one breast, and there will be a letdown on the other side. And it used to be that we used things like breast pads to keep that milk from going other places. But that is wasted liquid gold. So don't worry. Now there's a collection. This is a suction bulb. It reminds me of a JP drain, kind of, where you squeeze, put it on your breast, and then while you're nursing the baby, it's a passive collection. And women will tell you they can get 1 ounce or 2 ounces. And in those mamas that are so worried about every little bit, this makes a big difference for their mental health and for them feeling comfortable that they're supporting their babies. And then my favorite question. My mom says I have to pump and dump. Do I have to pump and dump? Mastitis is one that comes up. For those of you that had a chance to go by the EPIC booth, there's a new mastitis protocol that came out from ABM. I encourage you to get a copy of it. When people have mastitis, the best thing that we can do is encourage them to empty their breast milk. Now, sometimes it's a different color, and it's still okay for the baby to have, right? You do not have to pump and dump that milk. It's fine. We're not going to give you an antibiotic that's not okay for the baby, too. It is okay to continue to direct feed that milk. Can I drink? Well, what are we talking about? Are we talking about coffee? Sure. The guidelines from the different societies about coffee are pretty straightforward. They recommend 200 to 300 milligrams of caffeine a day. So that's like 1 Starbucks. Or if you make coffee at home, probably 2 or 3 cups. Now, as a practicing OBGYN, I perhaps have more than 200 or 300 milligrams of caffeine in my days, particularly when I'm up in the middle of the night with a baby. So the good news is the baby's fine. You do not have to pump and dump. You absolutely can have caffeine. What about alcohol? Well, that's a little bit more, there's more opinions, right? All of the big players have opinions, and you'll be shocked and dismayed, but they are not the same. In ACOG, they've got a nice table that kind of compares them, but the Contemporary OBGYN Journal did a really nice kind of synopsis not long ago. It was 2018. And basically the pearls are the level of alcohol in the mom's blood mirrors the level of alcohol in the baby, right? So if you have one standard drink, it raises your blood alcohol 0.02, and the baby is going to have a similar 0.02, right? It is fine to have a drink at a wedding and nurse your baby. If you are going to the bachelorette party in Cabo, you can still express that milk, and you should when you're separated from the baby, because don't take the baby to the bachelorette party, okay? And you can keep it, right? You don't have to pump and dump. You can express it, and then you can keep it for when you get home. Anecdotally, we've all heard patients say, oh, my mom said that if I drink a beer with my last nursing session at night, it's going to increase my supply. Well, there's actually data that says that probably it doesn't. And that's one of those places where people's anecdotal experience sometimes is not the same as the data that we have. There are studies that say that it can affect infant sleep, that they don't sleep as well with alcohol, but I'll be honest with you, 6-week, 12-week, 6-month-old babies, they don't really sleep really well anyway. And it's not a bad thing to limit exposure. If you're really, really worried, you can take that express milk from the bachelorette party and separate it into 5 or 6 bottles, and then fill the rest of it with non-bachelorette party milk to make up the volumes, right? I didn't realize this until a patient mentioned it to me, but there are test strips that you can buy to dip in your milk to see if there's any alcohol in it. Don't do that. Don't do that. It's fine. They're fine. What if mom has to have surgery, right? My anesthesiologist said, I have to pump and dump. Oh, no, you do not. Oh, no. I'm smiling at Dr. Hagens, who's sitting over in the corner. She's one of my residents. I occasionally have an excitable side, and I happened to be in pre-op when one of the anesthesiologists told one of my moms that she had to pump and dump. And I might have been on my 3rd cup of coffee or not, and I chased this OWG, old white guy, around the corner. You know, hey, I don't know if you know it, but that's not true, right? I have a reference for you from your anesthesiology society in 2017 that says, it's fine. I'm going to get you that reference, right? So then I run to the surgeon's lounge, and I'm like frantically pulling these things and printing them. And we get to the OR, and OWG says, turns out you're right. Cool. We're in agreement. Right? You are the best advocate for your patient. Remember that success goal? If she wants to breastfeed through a year, this is how you keep her breastfeeding even though she's got to have her gallbladder out. You can advocate for your patients. I really, really like this picture because it makes it very easy. It comes out of the Anesthesiology Journal in 2017, and there's a whole bunch of words that go with the article, so if you like words better, it's there. But I thought it was really, really a nice visual. And now the resources, right? Because God bless her, we love Sarah and we love hearing from her. But when she calls at 2 o'clock in the morning about her cracked nipples, we are going to be excited to tell her about other resources that are not you on the phone, okay? So local resources. In our hospital, we have an amazing lactation services, and they actually have an outpatient clinic. And I've been at Wellstar for 6 years. What I didn't realize until probably 3 years ago was you can write a referral and they can see the patients as needed in an outpatient setting, right? They have the fancy scales where they can do a weighted feed. Are you guys familiar with this? You come in, you weigh the baby nurses, you weigh the baby again, and you can tell from that little change in weight what volume of milk the baby has gotten in that direct nursing session. Do not buy that scale for your house. In Cobb County, where I practice, our public health department has breastfeeding support. So you can go to one-on-one consultations at the health department for breastfeeding. And that's a great resource that we don't use very often. Georgia OBGyn Society, y'all have heard of that. They have a breastfeeding committee. Caprice was sitting somewhere in the audience earlier. And there she is, and she and Dr. Callens have been integral in getting this committee up and running. She's also to blame for my talk, so we'll talk about that later. The AAP has a Georgia chapter, and we have an amazing certified lactation consultant in Claire Eden, who's also in the room with us today. And they have put together this really amazing resource that's called EPIC. Now, my EHR is EPIC, and the first time Dr. Callens and I started talking about EPIC, I was really confused. But I love EPIC, and I'm all about smart phrases, so I'm down. And she was like, no. EPIC stands for Educating Physicians in Their Communities, right? I'm fortunate enough to work with residents, and they keep me on my toes. So it's not very long before I get exposed to whatever new committee opinion or whatever new practice bulletin is out. But in the community, when you're busy and you're working in a private practice, you don't always have as many opportunities, and this is a fantastic resource. There are webinars, there are links. If you haven't checked it out before, please do. It's really, really a great thing. And then this is also from the GOGS site. The Georgia WIC is a great resource. They actually have breastfeeding. Now, when I was a resident, I felt like WIC wasn't the best support for our patients because they pay for formula. But it's really changed over the years, and they do a lot of breastfeeding support, and the W stands for women, and if you're nursing, then it changes the allocation of support that you can get. So this is a great resource. And then Zip Milk. Holy cow, we are the coolest people ever. Did you know you can put your zip code into this website, and it will tell you what lactation support resources you have? I have a resident that's looking at a rural practice, and one of the places that she's interviewing is in North Georgia. And I'll be honest, I have no idea what lactation support resources there are for North Georgia. And I know when I was at Augusta, we often delivered patients from very far away. I don't know what the resources are in Statesboro or some of those smaller communities along the way. So you can put in your zip, and you can get access to what it is. And the other thing that I really liked about this website, thanks Claire for telling me about it, is that landscape of breastfeeding support. There are a lot of different terms or titles or certifications for the people that help with breastfeeding support, and they have a really nice kind of primer about what each of those consultants do and kind of the role that they play in the support. One of the things that I wanted to point out is this mother-to-mother support. Sometimes having someone who is going through the same thing or has been through the same thing resonates in a little bit different tone than the doc in the office. So if you haven't done it yet on your phones, do it later today. Get on Zip Milk and see what your resources are. Dr. Milk, how many of the physicians in the room know about Dr. Milk? Okay. So Dr. Milk is Dr. Mothers Interested in Lactation Knowledge. And it was founded in 2009 by Dr. Lori Jones, who is an IBCL, I never get it right, she's a lactation consultant. And she realized that one of the patient populations that were most likely to not meet their breastfeeding goals were physician moms. Because we're busy, because we wear too many hats, because we're busy. And so she founded this society, and there are over 40,000 members now. And I will tell you, the stuff that comes across Dr. Milk is amazing. That anesthesia resource, that's where I heard about it. The alcohol stuff, that's where the conversation started for me. In the middle of the night, when you're up with a baby and or a pump, there's always somebody on Dr. Milk on Facebook that you can ask a question of, right? And in our Be Exclusive, Dr. Milk welcomes anyone who identifies as female or is interested in breastfeeding medicine. The only exclusion criteria for this particular resource is cisgendered men. So, sorry guys. Academy of Breastfeeding Medicine. This is really cool. They have so much information. One of the neat things is the protocols. I mentioned earlier that there's a new ABM protocol on mastitis. The really, really cool thing is that the protocols are in front of the firewall, so you don't have to be a member to get them. And they're in multiple languages. Haitian Creole is the one we're getting in my office lately, and they've got some Haitian Creole handouts. So I thought that was pretty cool. Students, it's only $25 a year to join. Residents, it's only $50 a year to join. The rest of us is $300 a year, but it's a society, so it's reimbursable. Infant risk is one of my particular favorites for medicines, right? I was joking with one of the ER docs that's here today, and I said, you really ought to come to the breastfeeding talk because you miss opportunities, and he was like, yeah, that's okay. Even docs that aren't OBGYNs can have resources that don't cost them anything where they can look up the medicines, right? And patients can call this as well. Their call center hours are okay, but even better are the apps that you can have on your phone. Now, I will confess, I was broke for a really long time. I don't pay money for apps. But this infant risk app, which was $10, is on my phone, and I use it all the time. Right? We have these complicated patients who come in on medicines that I don't know, that I haven't seen, that I don't recognize. And all I have to do is get on the app, 2 a.m., whatever. And it's really nice. They also run an app for moms, and I'll confess that I haven't been on that app before. But my understanding is it's the same information, but more tailored for patients than providers. And then the WHO. The WHO has this great 10 steps to successful breastfeeding. It's a wonderful pictorial. It was the basis in many ways for the baby-friendly certification that a lot of our hospitals have. And it's a really great resource for people around the world. So I am really excited that the tea and all the medicine kept me from coughing. And I'd be happy to take any questions if you have them.
Thank you so much. Great talk.
Oh
yes, question.
Sorry. So, one of the things I see 6 weeks, 8 weeks down the road is moms that come to me and they have not slept more than 90 minutes at a time. And I'm like, okay, well, can we give the baby a bottle or can you skip a feed? No, I have to pump every 2 hours. How do we balance mom's mental health with breastfeeding?
It's really hard, right? And that's where it gets into how is this patient defining her success? So in that patient who is committed, I say, who is your support system, right? Because if you want to nurse every 2 hours, I want to support you in that. But you don't have to get up to get the baby, right? Who can get up to get the baby? Who can change the baby's diaper, right? All you got to do is flop over, show a boob, go back to sleep. Who can you enlist to help with those other things, right? In those moms who that's their definition of success, I tell them the only thing that you're responsible for is you and that baby. Somebody else can do all of the other things. Even if your husband doesn't clean well, it's okay. It's not forever. So looking for other sources of support and recognizing that having that conversation about giving a bottle isn't going to go anywhere, and being able to kind of pivot to the next support system.
Okay. So I think getting them to the point where they're feeling comfortable with what they can do and helping them find a system that works for them rather than trying to fixate on meeting criteria they've been kind of stuck on, I think, is the trick.
Yeah, and that one's hard, right? Because there's all of these influences that aren't us. I had a patient in my office the other day, and she was doing a great job. She had a great hold. She had a great latch. You could hear the baby sucking. And the resident had told me that she was breast and bottle. And I said, okay, how come? Oh, I didn't ask that. Okay, well, let's go ask, right? She said, oh, well, I'm worried that I'm not making enough. I said, okay. What makes you worried? Well, I can't tell how much he's getting. I said, okay. Is he growing well? Yes. Does he wet the diaper? Yes. You're doing great, right? And sometimes all it takes is to hear from physicians, because believe it or not, the things that we say, they do hear. It's the nappies and the weight, right? If they're wetting diapers and they're growing, then you're doing okay. So looking for other ways to give them parameters that they can hold on to instead of all the things that other people are telling them.
Awesome. Wonderful. Thank you. And one more thing I will share that a patient taught me that I wish I had learned. She told me she froze her breast milk in ice cube trays because she knew that was 1 ounce and that she didn't have to thaw out an entire bag at a time. She could allot how much she was going to feed instead of wasting a whole bag if the baby didn't need it. So nice tricks that we learn from our patients sometimes.
That's awesome. The thing that I learned that saved me was pumping in the car, right? 20 minutes to work, that's your first pump of the day. Get it done and out of the way.
Thank you so much, Debbie. That was a wonderful talk. I was just wondering if you could comment a little bit on GOGS and how you discuss that with your patients. I feel like a lot of patients going back to work early, they want a quick fix, just like those trying to lose weight want a quick fix.
Well, we are American, so, we need it now. That's a difficult conversation because a lot of what's used worldwide is not available here. When I talk to my patients about it, the one that I tend to use is Reglan. There's a 3-day taper that I've had a lot of success with. And if you look at the data, if they don't have response with that 3 days, they're probably not going to have response longer than that. So that tends to be where I start. You'll have patients say, well, I can get Dom from Canada. Should I try it? What about Fenugreek? What about all of this stuff? And you know what? It's probably not going to hurt, and you are welcome to try it. And I have one patient who swears the lactation cookies were the thing. The cookies are delicious. Eat the cookies, right? So try and, if it's a conversation about prescriptions, Reglan is my go-to. If it's a conversation about all the other things, then just kind of running through what's out there and what they can try and seeing what works for them. And preaching frequency, right? Because those moms going back to work are also the ones that are like, I really only want to pump twice a day. That'd be great. That's not going to cut it.
Yes. Thank you so much.
Dr. Matthews?
Yeah, 2 quick questions. There seemed to be a cultural difference in the breastfeeding rate. Do you find that to be the case where you are, and how do you get around that? And the second question is the cost of the pre-made breast milk. Is it covered by insurance? Because one of the issues, at least at our institution, was the cost, and the institution couldn't handle that.
Yeah, both good questions. There does seem to be some cultural differences. In our practice, as I'm sure most of you, we see many different. We have lots of Latinas. We have a growing patient population from Haiti and from Africa. And there are some very different ideas of what's normal and what's accepted. And so just being able to make it more normal helps your initiation rates, right? If you have a resource that you can go to that has a person who looks more like the person you're talking to, that sometimes lands in a little bit different way. Many years ago when I was a resident, there was a WIC peer counselor who was this amazing lady who had nursed twins. And when I found out I was having twins, she was the first person I thought of, right? Because she was part of my normal, because I had had that exposure. So just looking for ways to increase the exposure that each of these cultures have to this idea of breastfeeding being so good. And I think looking for those external factors, right? We are talking a lot about maternal mortality, and if you think your patients don't know about it, you're crazy. They know. right? They are hearing the same things we are. So having another resource to go to, hey, I'm so excited about this. Oh, well, no one in my family has ever done it. Okay, but you can, and it'll reduce your stroke risk. And you know, Georgia, we need all the help we can get. So looking for those ways. As far as insurance covering things, some insurance will cover the pump. Insurance doesn't cover the stuff. Some insurances do, but not many. And it does get expensive, which is why some of those reusable systems like the mason jars are really nice. The kind system, that's the like swanky one, is super expensive, cost prohibitive for a lot of people. But there are less expensive ways that you can meet the same goals.
We do. We have a virtual question from Chelsea Michael. She says, are there telehealth lactation consultants available that you are aware of? You mentioned Statesboro, which is where I practice. We have a single lactation consultant who is hospital-based only, and one other lactation consultant from a Savannah branch who will see outpatients. We are just very limited in this resource, and there are many more patients than one outpatient office can handle.
Yeah. That's a great question, and I don't have a better answer. I 100% would encourage Chelsea to look on ZipMilk. I know that on Epic we have resources for providers that are virtual, and I can't promise, but I would really like to hope that there's some telehealth. I know our institution is very far away from Statesboro, but I know we did some telehealth, and they still do a support group that's virtual, that's not limited to people in our region. So I think there probably are resources out there. You might have to dig a little bit, and I'd encourage you to do that.
Hey, I'm Sally McSwain. I practice in Atlanta. So I'm 2 years out of residency, and I, like many of you, my postpartum rounds took place as an intern. I was in, it was the wee hours of the morning, and I was trying to spend as little time on postpartum rounds as possible. You got to get in, you got to get out, then you got to get over to labor and delivery, and the questions are breast or bottle, what do you want for contraception? It's just you're trying to get through it as fast as possible.
Right.
So in training, I feel like, oh, you want to breastfeed? The lactation consultant, I'll put in a consult, they see you later today. I knew who the lactation consultants were. They were purple scrubs, but I did not know anything about breastfeeding, finishing residency 2 years ago.
Right.
Transition into private practice life, the part of pregnancy that I felt least prepared for were the breastfeeding questions. Luckily, 9 months into practice, I had a baby, and I like to joke that breastfeeding has been kind of my main hobby for the last 14 months. And I've learned a whole lot from personal experience. How do you see breastfeeding and lactation knowledge in your resident curriculum? How do you see it with evidence? Because you're fighting these myths with evidence. I just feel like there's so much hearsay about lactation. There's
right.
so much, there's a lot of people in the space, and there's a lot of different voices. And how do we as physicians bring those voices together and present our patients with evidence and not with hearsay?
Right. Man, I wish I had an easy answer for that one. One of the conversations Claire and I have had multiple times is how to bring all of the different people to the stage. Right, in my hospital, we have a new committee that's meeting to talk about the dialogue about contraception. Because what was happening is we were saying Nexplanon doesn't hurt your supply, and lactation was saying it was. And so our patients were getting very different messages, which doesn't suit anyone. And so I think that's step one, right? Have these conversations out loud in your practice with the players at your hospital. Figure out who the players are and have them. Ask the patient, not who told you that, but, oh, that's interesting. Where did you hear that? Get them to buy in a little bit and having that conversation. In a perfect world, I would have 30 minutes to spend with every patient, and I could work on latches, and I could talk about frequency, and that's just not how it goes, right? So having a way to let them start the conversation, having an opening so that they can tell you what they're hearing, having that relationship with them, identifying somebody in your office who is passionate about breastfeeding like you are and can be a resource. I'm so glad you asked that. I have the best person for you to talk to, right? In my office, that's an OB nurse because her time is a little bit less scheduled than mine. So just looking for ways that you can make little tweaks while we work as the system to overhaul all the people at the table. Thank you.
Okay. Thank you so much. That was a great lecture.